and good morning, everyone. Welcome. I thank you for joining this learning series webinar today, Public Health Barriers in Addressing the Opioid Epidemic. Today's webinar is designated for 1 AMA PRA Category 1 credit, 1 ANCC contact hour, 1 ACPE contact hour, 1 AAPA Category 1 CME credit, and 1 ADA CERP continuing education credit. And for pharmacists claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has also been approved by NJOEMS for 1 EMT elective CEU and by the National Commission of Health Education credentialing for 1 MCHES credit, continuing education credit. I have a few housekeeping items to mention. PA Planner Dean Barone discloses that he serves on the Speakers Bureau of Ethicon, and all of our other faculty and planners have nothing to disclose. So now that we got through all of that housekeeping, I want to mention that today's webinar is jointly provided by the Partnership for a Drug-Free New Jersey and the American Academy of CME, Inc., and is being held in collaboration with NJ Cares, the New Jersey Office of the Attorney General, and the Opioid Education Foundation of America. And I thank them once again for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. I'm so pleased to welcome our expert panelists today. We have a really varied expert panel, and I'm really looking forward to hearing their perspective on public health, as well as what's impacting their work as they deal with the opioid crisis. We have Dr. Josiah Rich, who's a professor in medicine and epidemiology at Brown University. We have Michelle Calvo, the director of opioid response and policy for the New Jersey Department of Health. And we have Dr. Richard Jerriman, the interim dean at Rowan Virtuous School of Osteopathic Medicine. So I welcome all of you today. I thank you for joining us. And Dr. Rich, I'm going to turn the presentation over to you.
Wonderful. Thank you, Angela. It's an honor to be here. And I sometimes start off a talk with a bad joke, and I was just thinking about the wording of the Partnership for Drug-Free New Jersey, and I was going to ask about, I didn't know we were working towards free drugs in New Jersey, but drug-free does kind of seem like a pie in the sky, but I think what's not a pie in the sky is to make drug use as safe as it possibly can be. And of course, I've spent my entire career helping people suffer, deal with the fallout of drug use, and so I'm not a big fan of promoting drug use, but acknowledge that that's a sort of a human characteristic. So I started my career in medicine and infectious disease and public health, and then came to Rhode Island in 1994 as the AIDS epidemic was raging. We did not have effective treatment at that time. And Rhode Island was fairly unique, and one of only 4 states with more than half of the AIDS cases related to injection drug use, predominantly injection drug use epidemic. The reason for that was that the syringes had been outlawed in the state. It was a felony offense to possess a single syringe without a prescription, punishable by up to 5 years incarceration. I had a patient who had a dozen syringes in his pocket, no drugs, was arrested, and the judge wagged his finger and said, "I could send you to jail for 60 years, a life sentence for possession of drugs." Now, what that did is change the focus. As sort of a cat and mouse game between the cops and people using drugs. And that took the focus away from other illegal behaviors and even possession of drugs and focused it on syringes, so that people changed their behavior. They didn't want to carry a syringe because they knew they would get arrested. So they would go someplace to buy their drugs. There'd be a syringe there. They'd take the syringe, they'd use it, and then they'd leave it there because they didn't want to get caught with it. And the next person would come and do the same thing. And it was really driving the AIDS epidemic in Rhode Island. So I got involved in trying to diagnose, treat people, and connect them to care. It was Willie Sutton. They asked the bank robber Willie Sutton, why did he rob banks? And he said that's where the money was at. Well, the money with HIV at that time, a lot of it was in the Department of Corrections. So Rhode Island has a combined prison and jail system, unified system. And I started going there half day a week. And during the 1990s, a third of the people in the state were diagnosed with HIV, were diagnosed at the Department of Corrections. So that's a pretty big slice of the pie to be ignoring. So I spent a lot of my career working on dealing with HIV and addiction, became an addiction expert along the way, done a fair amount of research, and AIDS has been really a major defining part of my career. Now, at the peak of the AIDS epidemic in the US, 50,000 Americans died in 1 year. That was horrible. It was a Holocaust. It was terrible, and I was at the front lines, witness to that. And a few weeks ago, the CDC announced that the estimates for the for the recent deaths from overdose were over almost 109,000. So over 100,000 for 2 years in a row. That's double what the AIDS crisis was at the worst of it in America. So this is, I was very discouraged to hear that number, because it means that, I kind of thought that we went up to 100,000 because of the disruptions of COVID, and that was kind of a one-off, a perfect storm of terrible things. But this, now that we're still increasing, is really, this is terrible. This is really an all hands on deck moment. Now, I mentioned my incarceration because it's a key part of what's going on with this epidemic. We had until about 40, 50 years ago, we had the same rate of incarceration as all the other Western nations. And then we took off and we had this mass incarceration. And it was really driven by two factors. One was the deinstitutionalization of mentally ill, which was liberating and wonderful for so many, but so many fell through the cracks. The second was the war on drugs, and really the war on drug users. It had a racist foundation that really was just a horrible miscarriage of justice, and we're still paying the price to this day. Now, the reason that was allowed, in a large part, was because of our own society's attitudes towards people who use drugs. The tremendous stigma that those people are somehow different. They're those people. They're less than. They're less deserving. They behave in ways that it sees that they don't care about their own health, so why should we care? And we can just write them off. In fact, the treatments, we're going to push those treatments to those dirty methadone programs on the other side of the tracks, and we're not going to incorporate that into mainstream medicine. And in fact, we're not even going to teach about medicine, teach in medicine about addiction. We're not going to teach people how to understand it, how to diagnose it, how to treat it, how to prevent it. And to this day, we still are way behind on that front. And I would suggest that the very start of this opioid overdose crisis was kicked off because physicians were overprescribing, and they were overprescribing because they got sold a bill of goods from the pharmaceutical industry and certain bad actors, and they bought it because they had no idea about addiction, because they never really learned how to take care of it and how to understand it. If they had, I think this whole thing could have been much less and maybe even avoided. Now, this epidemic is very, very dynamic and very big. It went from primarily a prescription to then people transitioned to heroin when they could no longer get pills, to the heroin supply worldwide got stressed. And because heroin is a semi-synthetic, you need both some poppy plants grown and processing. The supply was somewhat limited, and that pushed innovation to synthetic, fully synthetic, and predominantly fentanyl-related compounds. And now it's evolved into the fourth stage, which is polypharmacy. It's opioids, predominantly fentanyl, plus stimulants and other things mixed in. And the whole time we are getting more and more behind. And what we really need is treatment. And when I say treatment, I mean the medications. Those are the most effective thing we have to treat opioid use disorder. And that's predominantly methadone and buprenorphine. Naltrexone has a role to play, but it's far less durable, in my opinion. But we don't have the manpower to prescribe enough methadone and buprenorphine, so we really have to move quickly to ramp that up. From an overall strategy perspective, we know many things that work. We know that buprenorphine works. We need a lot more prescribers. We need, there was this call for treatment on demand, and that was the kind of a rallying call. We need treatment on demand. Well, nobody should have to demand this treatment. In fact, people with opioid use disorder get treated so poorly by everybody, basically, but especially the healthcare system, which is supposed to be helping them, and to make people demand it. And if you looked at what some people with addiction have to go through, if we did that to people with diabetes, that, oh, we're going to arrest you if we find you with a candy bar, or people who smoke cigarettes, oh, sorry, you already tried a treatment program, didn't work, so we're not paying for it anymore. There really needs to look at what is going to help people to actually get high quality treatment on a widespread. So the overall strategy that we need is we need to double down on the things that work, and we know that treatment works. So that should be available across the nation, and particularly among minorities, people of color, and other disadvantaged populations, because that's where the epidemic is going right now, the fastest. And then we need a lot of innovation and a lot of tinkering with treatments that work. Try and expand it. So expand into pharmacies. Let's get medications into pharmacies so that people can just go to the pharmacy and get treated, and other innovations. I think my time is up now, but I look forward to the discussion and hearing the two speakers. So thank you all.
Thanks, Dr. Rich. Thanks for giving us that background. I think it's so important to know the roots of this issue as we look at developing solutions and addressing it every day. So thank you. I'm going to welcome now our next speaker, Michelle Calvo. Michelle, welcome, and I'll turn the presentation over to you.
Thank you, Angela. And thank you to NJ Cares and the partnership for inviting me today. Also, thank you to Dr. Rich for those framing comments, very helpful for setting the context. So today I'm going to be speaking about how we're driving public health data to action to prevent overdose in New Jersey. I'm going to set my timer so I don't go over, and I may go through my slides pretty quickly just so I stay with time, but I'm guessing that the slides will be shared afterward. So next slide. So I'm gonna, I have a few slides on with data, just to contextualize where we are in the overdose epidemic in New Jersey. New Jersey has hovered around the national average. You can see New Jersey all the way at the bottom. This is not all states. These are just states with higher rates than New Jersey. And the national average is there right above New Jersey. So New Jersey in 2021 fell below the national average, but the prior year we were right above it. So we've kind of hovered there for a few years. But that said, like many other states, we still are seeing a really tragic number of deaths every year, right around 300 deaths. That represents over 7 New Jersey residents dying every day. Also want to just recognize that this is a really tough subject, and I'm sure many of us on the call have lost friends and family at this point, and just want to honor that. By far, overdose is the leading cause of injury in New Jersey, higher than car crashes, suicides, homicides combined. Next slide. So these are our overdose death rates in New Jersey from 2012 to 2020. So you can see that we really had dramatic increase from around 2015 to 2018, and then have kind of seen a plateauing of the rate. Since then, we did see a small decrease in 2022, but unfortunately thus far in 2023, we're actually trending a bit up from 2022. So it seems that we are simply continuing to see a plateauing of deaths at this very high rate in New Jersey. Next slide. I'm going to skip this slide actually for time, just to plug that we have a lot of non-fatal overdose measures that we collect at the Department of Health. And a lot of this information is on our website, and the link is there. Next slide. So these are overdose death rates by race and ethnicity. And as Dr. Rich mentioned, this is really important when we talk about overdose, that we don't talk about the rates overall, that we look by specific community, because really, if there's one thing I want to get across from my presentation, it's that the overdose epidemic looks really different by community, and our responses have to be rooted in community for them to be effective. So the blue rate is all New Jersey residents, and you can see that plateauing. The purple rate is white residents. So we started seeing those deaths going down in 2018, but Black residents in teal and Hispanic residents in green have continued to climb, and Black residents, the rate started exceeding those of all other races in 2018, and have just unfortunately since what is displayed here has continued to rise. Next slide. So I'm going to show a few demographics by race and ethnicity. So by geography, we can see that for white residents, there's a heavy concentration of deaths in the southern portion of the state. And for Black residents, a really high concentration in Passaic County. And just want to emphasize, really important to disaggregate here so we can target resources appropriately. Next slide. So this is a breakdown in rates of overdose death by age group and sex. The blue bar represents females and teal represents males. So across all racial and ethnic groups, males are disproportionately impacted by overdose death. But if you look at the age groups, next slide, it looks very different based on race and ethnicity. So among Black residents, we see that the most disproportionately impacted groups are older residents. Among white residents, it's a younger population, and among Hispanic, it's sort of middle age. So all this to say, again, that the epidemic looks very different for different communities. And I'm going to talk now about some interventions and how we're trying to tailor to communities. Next slide. And before that, I did want to mention xylazine because this is an increasingly important factor in overdoses and substance use in New Jersey. So we actually have seen xylazine in our drug supply since 2016. But particularly started seeing really dramatic increases in 2021 and 2022. Right now, about 45%, almost half of, it says a third here, but I have more updated numbers. Almost half of our heroin and fentanyl supply, or at least based on the seizure data from the state police, contains xylazine, and pretty much all illicit xylazine contains fentanyl. About 99%. Xylazine, for those who are not aware, is a veterinary tranquilizer. It's not FDA approved for use in humans. It's not an opioid, so naloxone does not reverse its effects. However, I always have to say that you should still administer naloxone if you suspect an overdose, because it always is accompanied by fentanyl, at least in New Jersey, and what we're seeing so far. Every county of New Jersey has had a xylazine-involved overdose death from 2021 to 2022, and about 10% of those deaths involve xylazine. But I do want to caution that right now we're really learning a lot about this drug and its role, and really just starting to understand through surveillance. And it's difficult to tease out the role exactly that xylazine is playing in overdose death risks. And there's some research actually showing that the contribution to lethality of fentanyl appears minor, but we'll be learning a lot more about this over time. So some of the harms associated with xylazine include severe wounds, heavy sedation, and a really complicated overdose response. And I will talk a little bit more about this a little later. Next slide. So I want to shift into talking about our prevention work in public health in New Jersey. One of the most important intervention points that we have in overdose prevention and care is in the EMS setting after someone overdoses. Often EMS are the only healthcare providers that a patient sees following an overdose. So just want to highlight two programs. One is our 5 Minutes to Help program, which educates first responders about overdose reversal and how to address mental health needs of patients with substance use disorder, covers strategies to address stigma, motivational interviewing, trauma-informed care, and approaches to connect patients to harm reduction and treatment resources. We also supply free bags for EMS agencies with resources about harm reduction services, which accompanies the naloxone that our addictions agency provides. Next slide. So harm reduction is a huge priority of this administration and the Department of Health. Harm reduction is a community-driven public health approach that emphasizes engaging directly with people who actively use drugs to prevent infectious diseases and overdose, to improve health and connect people to care, but really fundamentally to meet people where they are to achieve the goals that they define for themselves. So harm reduction centers are syringe access programs. They can offer services in a variety of ways because they are really rooted in community. They can offer mobile services, services through drop-in, even services through the mail, which I'll talk about in a little bit. They also can provide access to a whole range of services like access to food and laundry and so on. Next slide. In New Jersey, we unfortunately, up until about 1.5 years ago, had a municipal requirement for syringe access programs. So we currently only have 7 authorized centers, but this was recently removed through the law changing, and we have recently released rules and are accepting applications for new harm reduction centers, and we'll be releasing funding in August. So it's really an exciting time for harm reduction in New Jersey. And the rules were designed in such a way that really any organization, whether it's an FQHC, an emergency department, a volunteer-run outreach organization, any organization with the capacity to offer harm reduction services would be eligible to apply. And we would like to see every community have access to a harm reduction center. Next slide. So I want to talk about overdose fatality review teams because we have many of them in New Jersey. If you didn't know, we actually have one in every county, at least one in every county, actually. So overdose fatality review teams are based on the maternal mortality or child fatality review team model. They conduct multidisciplinary reviews of overdose deaths with a focus on social and structural contributors to death. And the goal is really to identify community specific interventions to prevent future deaths. Next slide. You can skip this one, actually. This is just showing that we have one in every county, and we've been running a grant program for 3 years. And these are just some examples of the tailored interventions that OFRTs in New Jersey have been able to develop based on the reviews that they're conducting. So, echoing what Dr. Rich mentioned about the really important role of incarceration and risk for overdose and drug-related harms. So a lot of our teams are focusing on that critical window. Also focus on motels as an intervention point. So next slide. This is a new initiative that we started within the past 6 months based on some analyses that our surveillance team conducted of EMS and law enforcement naloxone administration data. So they identified the types of locations and the actual locations of hotspots of overdoses within the state. And these include transportation centers, correctional facilities, alcohol outlets like bars or liquor stores, hotels, and apartment complexes. And I wanted to emphasize that we found that middle-aged Black non-Hispanic residents are overrepresented in hotspot data. So, in order to drive down disparities, we are focusing a lot of resources on hotspot areas. So as a result of this analysis, we designed a hotspot initiative with various components. So one is really another effort to support community-based and community-driven interventions. So we're partnering with over 35 local organizations throughout the state, but particularly in those high disparity, high burden areas to support material resources really in a low barrier way, often to organizations that don't have access to state resources. So we're providing them things like naloxone, hygiene kits, wound care kits. And then we also have some staff that we brought on, some health educators who can provide a little bit more staffing support to some of these organizations. And then finally, we are distributing naloxone kits to be stored within AEDs at these hotspot locations like train stations and motels. Next slide. This is just an image from one of our health educators placing a naloxone kit in a tree for someone to just discreetly take in one of our hotspot locations. Next slide. And just wanted to mention that we are also supporting mail-based access to services, which is a really important entry point for services for people who may not have transportation, who just don't feel comfortable going to a pharmacy or may not have access to a harm reduction center. Next slide. This is an example of some of the health communications that we've been doing, particularly around xylazine. You can skip this in the next slide since I'm at time. I just really wanted to emphasize, you can skip this and just go to the last slide, that we think it's really important to integrate data into our programming, but just as important to integrate those on the ground, people with living experience of drug use, to ensure that the response is community driven and really tailored to what community needs in order to address a lot of the challenges that we have right now with this epidemic. So looking forward to the discussion. Thank you.
Thanks, Michelle. And thanks for that important information about New Jersey. It's great to see where the state is, in relation to other states and also the national average, and also for touching on xylazine. I know with many of our attendees in our audience, we've been getting a lot of questions and people looking for information, right, on that topic. So I think in the chat, we had done a webinar that addressed that topic pretty significantly back in May. So we'll put a link to that in the chat, as well as supplemental information to what you shared, Michelle, as well. So thank you for that. And any of those materials that you shared in your presentation, and we'll circle back to some of the questions that we have at the end of the presentation. But so thank you. And now, Dr. German, I'm going to turn the presentation over to you.
Thanks, everybody. First of all, I want to thank you all for allowing me to be here today. I'm going to give you a little heads up. I have a bit of a cold, so if I start coughing and or my head explodes, you will know why. So next slide. I would like to say I shared Dr. Rich in my experience. I actually started my career with HIV and AIDS in a little different way. I'm a physical medicine rehab doc who did pain management, and I dedicated the first part of my career to end of life. So I treated quite a bit of HIV and AIDS in regards to end of life, turned into pain management, and now I do both pain and addiction. And I have nothing to claim on this. Next slide. So I will thank SAMHSA, who is a grant that really provides this component of this talk today. Next slide. So we're primarily going to really concentrate on what we can do. We were mentioning a little bit earlier about naloxone. I'm going to go into this a little bit more, but this is really very still markedly underutilized, markedly underprescribed, and undertaught in our community. This is the one win that we can all have in trying to decrease the death rates when it comes to opioid overdose. Next slide. So what we really want to do is talk about and realize that these are best practice guidelines. So, and part of our talk is to provide direction to practitioners to help make their decision and realize that this evolves over time. And we incorporated expert experience, judgments, perspectives, and continued research in regards to naloxone and its benefit in the community. Next slide. So it's been around for a long time. It started in 1960s, where it was recognized as an opioid antagonist. Through the 70s, it was administered to IV and IM. And more recently, 2012, we have an intranasal applicator, which I'll go into in a minute. Next slide. So the intranasal applicator is really the most common form that's used both in the community and healthcare settings. It's easier to use in IM and IV. You don't need needles, and it always provides a consistent dose, and it's easy to carry around. Next slide. So why does it work? It's a short-acting opioid antagonist. So when an opioid binds to what's called a mu receptor, it will dramatically kick that off, that mu receptor, and it will bind to it. It takes about 2 to 5 minutes to work. Most people probably a little bit sooner. And it lasts 45 minutes to 60 minutes. There's no risk for addiction or tolerance. Next slide. Next slide. Can we go ahead and move to the, did you guys lose me?
Dr. German, I think we're having a bit of an issue with the slides.
Oh.
So if you can continue, we're gonna, I think, reload the slides and then we'll catch up with you if that works.
Sure.
Okay, sorry about that, everyone.
So I think a couple of things are really important to remember. When we talk about naloxone, to remember that it is a pure antagonist, right? People sometimes get that confused with buprenorphine, which is a partial agonist. The other thing is that the half-life, there we go, next slide, please. Right, for IV is about 1 to 2 minutes activation, both intranasal and the sub-Q IM. It's about the same, 2 to 5. So it's again, putting into that intranasal application is really important. Next slide. So again, I said before, about 45 minutes to 180 minutes. So why is this important? Because if someone has a large dose of fentanyl on board, you give them Narcan, they revive, and about 45 minutes later, they can go back down again. So it's very important to remember that it's not always one and done. And it's very important following an overdose that people have additional doses of naloxone that they may need to use later on. It's about 4 milligrams per spray. Next slide. It's metabolized through the liver. Next slide. And it's excreted through renally. Next slide. So we have several formulations of naloxone. And again, we're pretty much going to stick on the intranasal formulations. Next slide. So one of the challenges, I think, with naloxone for pretty much everyone is it is still costly. If you look at the generic naloxone formulation, it retails still about $42, and there's still many states that don't subsidize this. So for the average American, it's fairly costly to go in and just say, I just want to buy some naloxone to have it. Next slide. So of course we can do a deliver a single dose at any time. When you're administering it, you're going to wait about 2 to 3 minutes. I always err on the kind of shorter side with that because the higher doses of fentanyl may require a little bit more of a dose. You're going to alternate nostrils as you're doing that. So next slide. So when we think about intravenous formulations, we do have some dose differences between adults, neonates, and children. So if you look, adults have 0.1 to 0.2 milligrams, neonates are 0.1 milligrams per kilograms, and children are 0.01 milligrams per kilogram. Next slide. So do you need a prescription? So you can actually buy in New Jersey naloxone with or without a prescription. We highly recommend to get prescriptions because it really brings the cost down if you're an insured patient. But most pharmacies carry naloxone. You could also get them through community health organizations, needle exchange programs. New Jersey does Free Narcan Day, which they put out pretty much every year. Next slide. Legal considerations, can I get sued? And really the short answer to that is you really can't. Next slide. So New Jersey allows us to have standing orders where a clinician orders can be carried out by other healthcare workers. And we do this a lot. We do a lot of Narcan distribution centers. I'm a physician actually that writes the prescription for Narcan for our first responders and our police through most of South Jersey. And why is this important? Because it's harm reduction. It allows other people in the community to distribute and train patients so that they can respond to overdoses more frequently. We now have a community healthcare worker peer recovery coach, a school actually, and we're out there distributing Narcan. Next slide. So pharmacists, I think it's really important to remember that it's just not, here is Narcan and move on. You have to educate, train the patients when they come in, and just a constant reminder to all of us, next slide, that you don't use Narcan on yourself, right? So you really have to train other people to train and help our patients. Next slide. So the Good Samaritan Act says you will have no liability in treating people with Narcan. Next slide. Who tells us to do it? Everybody. The CDC, next slide. And the Department of Health, next slide. So what does New Jersey say? New Jersey says that if you're treating patients, the patient must have a history of substance use disorder and or about 90 milliequivalents a day of a morphine product or equivalent. We'll talk about that in a second. And or have valid prescription for opioids or benzodiazepines or other sedating agents. And really what I try to tell my physician providers are, give it to everyone who asks for it. Anyone can come in and say, I want Narcan. It shouldn't be asked another question. Yes, you can have it. Next slide. So if we want to do this in a much bigger way, obviously, we want to train facilitators, people who can help train in your hospital system, in your community, and go out and do patient education using certain resources in social media. Next slide. So next slide. How do we calculate morphine doses? New Jersey says we need 90 milliequivalents. To the right is a calculator dose. So for example, if you're on fentanyl 10 milligrams, you multiply that 2.4, and that would give you the morphine equivalent dosing. Once you get to that 90 by state law, you have to give Narcan. Next slide. If you're one of those people that just love to look at risks and like to use these types of products, there's the risk index for overdose or serious overdose in respiratory depression scale. This brings in other comorbidities that are really helpful, like COPD and mental health. Next slide. And what you do is you score it up, and if it's greater than 18, that person should get naloxone. Remember other medical issues such as elderly, decreased opioids and benzos, they metabolize it a little bit different and a little bit slower. So you want to make sure you keep all these things in mind. Again, give as much Narcan as you can. Next slide. And next slide. So again, there's a lot of formulations of naloxone out there. The easiest that you really wanted to give is going to be the nasal formulation. Next slide. And remember, you want to follow up. Did you use the naloxone? Why did you use naloxone? Do you need another script? Next slide. Next slide. And it's a constant reminder, like Dr. Rich said, is it's not just about the naloxone or immediate treatment, but it's getting into treatment to help with their addiction. So you want to make referrals to substance use provider education and get them into medications that can help. Next slide. Everyone should do it. Dentists, nurses, medical students, medical assistants, everybody in the healthcare community owns this. Next slide. Remember that it's important that when we do administer to an overdose in a community, that you don't forget about calling 911 and get help out there as soon as possible. Next slide. Train the trainer, you don't use it on yourself. Next slide. And there's different ways of teaching how to do it. The chuck and check technique is give small details of information to your patients when you're training them and ask them to give it back to you. Next slide. Lots of handouts. You can use these, copy them, and distribute to your patient population and community. Next slide. Just to remember that naloxone saves lives. It's not a stigmatized world where, oh, if I give Narcan or I distribute or I have it, it's saying it's okay to use. Absolutely not. Dr. Rich remembers a time, like I do, when people said, if you give condoms out to people, it's saying it's okay to have sex, and people literally marched in the street. And it's the same today with naloxone. So it's critically important we get this out in the community. Everybody who wants it, everyone should carry it. Thank you all. Next sentence.
Thanks, Dr. German. Before we go on, again, apologies for the little technical hiccup, but I think you kept right along with that. So appreciate that. You did have a slide that we got a number of questions about in the chat, just about nurses, dentists. There's a lot of questions about who can prescribe naloxone, and not sure if that slide was saying that who could administer and prescribe. So
Yep.
just go back to that for a moment before we go to the questions.
That's about patient education.
Okay.
So everyone in that slide should be involved in training in patient education on how to administer, how to get naloxone.
Okay,
Remember,
great.
most pharmacies should be carrying naloxone. We actually, unfortunately, did a study in South Jersey and demonstrated a lot of pharmacies are not carrying or carrying enough. We're hoping that it's more accessible now that the naloxone rule has been passed in New Jersey, where pharmacies have to carry it and distribute it to people who are on opioids at 90 milliequivalents or more. So we're hoping to see that translate to more Narcan in our pharmacies.
Okay, great. And just to add to that, I know, Michelle, you were adding some information in the chat about some different resources that we have and how to access naloxone or where to get additional information on naloxone. So that information is in the chat. So thank you. I'm going to start off with this question because it seems like it's been pretty prevalent in the chat. And Dr. Rich, I'll go to you first. I mean, there seems to be so much stigma around addiction, but in the general public, but also when we talk about our medical community and when we talk about medically assisted treatment and the stigma that surrounds that. So, Dr. Rich, can you start us off just addressing that? And
Absolutely.
What we can do.
So the physicians are not immune from the stigma that everyone else in the society has around this disease. And one notable contradiction is we are saying, okay, well, this is a disease, so we need to treat it. We need these treatments. But at the same time, it's a crime. So, come here into treatment. However, if we catch you, we're going to arrest you and we're going to punish you. And the Europeans look at us like we're absolutely crazy. Like, don't you know punishment doesn't work for this disease? That this disease is a disease, and treatment does work and punishment doesn't work. There was a question about from Marie Barone about does buprenorphine or Suboxone, trade name Suboxone, buprenorphine, is it a valid, effective, and appropriate treatment for opioid use disorder? Yes, yes. If you learn nothing else, if we got, I would say, half the people with this disease walking in the street, they need a little bit of buprenorphine and a little education about it, a little pat on the back, and they're going to be fine. They're going to be easy. And yet the physicians have this stigma. I mean, we've been able to prescribe buprenorphine for 20 years, and 95% of us have said, no, thank you, because we don't like those people. So the stigma is really very real. Getting rid of the X waiver is great, but it's not enough. I mean, I think there's going to be some that will come into the fold and start prescribing, and that's great. But we need to double down on the new people coming out of training, the medical students, the pharmacy students, all the providers, nurse practitioners, and the people in their training, the residency. Here in Rhode Island, I'm trying to push to say nobody should graduate from a medical school or a training program, a clinical training program, without having had experience, real life experience, taking care of people with using buprenorphine, because that's one of the biggest tools we have. And if we could roll that out and make it not available on demand, but widely available, encouraged, and supported, we would be way ahead of where we are now.
All right, thanks. And Michelle, can you add to that about how to eliminate that stigma of both harm reduction, addiction, harm reduction, medically assisted treatment?
Yeah, I mean, I guess I can speak from our own experience with EMS providers in particular. Part of what our training does is to address like what the reality of what it is to be responding to such frequent overdoses and the trauma that our healthcare providers are experiencing and why they may have that reaction and what compassion fatigue is and things like that. And getting them to kind of talk about their own, personal experiences with this issue. I think we found that to be an effective way to kind of break open the issue around stigma.
Can I add one more thing to that? And that is, we use buprenorphine products for pain, and no one talks about it. So in fact, it's the number one thing I write in the elderly patient population post-op is buprenorphine, because you don't have the respiratory depression components. So it's kind of interesting that we've been using this. There's buprenorphine products out there that are only indicated for pain, yet everyone thinks it's, the stigma of addiction. So I don't know if that helps people think of it in a little bit of a different way. But stigma is one of the biggest problems that we have. This is not using a drug to replace another drug. They're very different formulations.
I'd just like to add a couple things, if I might.
Yeah.
I mentioned the Europeans. Now, 22 years ago now, Portugal decided that they had a huge drug problem. In fact, the worst in all of Europe. And they decided this is a big problem, but it's a medical. So they took the problem away from the Minister of Justice, and they gave it to the Ministry of Health. So you deal with it. Trafficking, dealing, that still stays with the criminal justice system, but drug use, so personal consumption. And they really found if you are caught with drugs, it's still illegal, but it's illegal like, for example, driving without a seatbelt in the US. If you're caught, everybody knows that you have to wear your seatbelt, that's the law, but nobody goes to jail, nobody gets a criminal record, nobody gets their whole life turned upside down because of it. They get a ticket, they get coerced by the state to wear it. seatbelts and it works. You look out in the streets and most people are wearing seatbelts. So that's the approach that Portugal has took. They are now have the lowest rates of incarceration, lowest rates of HIV related to injection drug use, and they have 2% of the overdoses that we have. And if you talk to people in Portugal about addiction, they know it's a disease. They, here you say addiction and people think this is a crime. People should be locked up. So that's we should decriminalize possession of drugs and treat it as a disease. The other point I'll just make is that there's some statements in the chat about Suboxone or buprenorphine being addictive itself. That is false. People who want to get high, want to use a drug for illicit purposes, they don't go and find buprenorphine for that. It doesn't work. If you take it every day, you don't feel high. You feel normal. If you take fentanyl or heroin or oxy every day, you will get a high, but not with buprenorphine. So that's a falsehood. Buprenorphine, a lot of the things Dr. Germain talked about with naloxone should be the same with buprenorphine. I'm not advocating for diversion, but when it is diverted, it's diverted to help people treat the symptoms of withdrawal. So it is treatment. In fact, a number of states have now decriminalized buprenorphine because it's treatment. It's not a drug of abuse primarily. Thanks.
Thanks. And Dr. German, was there anything more you wanted to add on that question before we go to the next? No. Okay, good. Great. So we have a lot of people. Michelle, you mentioned specifically the spike in the Black population in New Jersey, and people are wondering what can they do? What efforts can be made to get information out to populations like Dr. Rich and Dr. German mentioned that aren't necessarily getting the information that they need, or that we're seeing these spikes in. So how? Any advice or tips that you can give anyone and what they can do?
Yeah, so I mean, I think I talked about some of it, which is like working with trusted community partners. I know like one of our partners at Vital Strategies, they recently had funding specifically for Black and person of color led organizations. So I think definitely working through trusted community partners and bringing in people with lived and living experience. But I think also just, again, like thinking about addiction and overdose and related harms as another health condition, and how we think about all health conditions and what we call in public health the social determinants of health. We need, things outside of healthcare to be able to address this issue. And we see the same racial disparities for, heart disease and hypertension and all chronic diseases, and all of those health outcomes. Maternal mortality is a great example. I mean, it's a horrendous example of the racial disparities we see. And things like housing, housing in particular, that's like such a huge factor that unfortunately are kind of sometimes out of control of healthcare providers. But at the end of the day, without addressing, the social and structural factors, also the policy factors, like how people are criminalized, and people of color and Black people in particular are disproportionately criminalized. I don't think we're going to see an end to this epidemic.
Could I add one more thing?
Please go.
Yeah, really good data out there on how patients are navigated to care, right? So we know that a lot of our Black and Latin community are navigated to OTPs, outpatient treatment programs, or methadone clinics. And Caucasian people are navigated more to OBATs, where they're more buprenorphine based. What's the difference? Methadone clinics, every day you have to go stand in lines, as opposed to going to an office like mine and be able to get buprenorphine, and if we have to stop looking at that How we navigate our patients, I think, are really, really important, and kind of how that alone can kind of break some of the cycle that we're putting our patients through.
All right, thank you for adding to that.
So
I know we
I'd
are.
like to jump in. There was one question about the relative naltrexone versus methadone versus buprenorphine. In our Department of Corrections several years ago, we decided to offer treatment with medications to all people who are eligible clinically. And we, the basic tenet of these three medicines, methadone, buprenorphine, also called Suboxone, and naltrexone, also called Vivitrol, is they block the effects of supplemental opioids, illicit opioids. They all three work if you take them. They all three don't work if you don't take them. And so a critical component of deciding which one to give to people is which ones people are going to take. And when we did that in Rhode Island, of the first 1,000 people that we offered this to, about 500 said, I want methadone and I don't want buprenorphine. And we said, well, why not? Well, I don't feel right on buprenorphine. I feel better on methadone. About another 500 said the same thing, except the opposite way with buprenorphine. And only a handful said, I want naltrexone, depot naltrexone, Vivitrol. And what we found is that, I mean, as a clinician, I'm delighted to have naltrexone in my toolbox as to offer something. But what I find is that most people don't stick with it. They take a shot the next month, and then they just kind of say, oh, I'm good. And then they end up getting reincarcerated when they relapse or overdosing. So I think that's that's sort of telling. Now, there was other question about, do New Jersey jails have access to methadone? Well, they should have access to methadone, buprenorphine, and even naltrexone, ideally. And it should be driven by what's best for the patient, including what the patient prefers, because that's the one they're likely to stick with. There is a nice website, the Jail and Prison Opioid Project, that maybe I can
Yeah, if you could share that, you can share that with us. We'll definitely share it with our attendees. Thanks, Dr. Rich. And I know we're coming to the end of our time. I did want to give everyone just one last opportunity to comment to our audience. I mean, we have public health professionals, we have EMTs, we have people who are impacted, we have doctors, dentists, nurses, many in the medical profession who are on with us. So just leaving with that. And Michelle, I'll start with you. One last word to all of our attendees.
I guess I would emphasize to trust people and their own lived experience. And a lot of like the issues that we have today are because, like we said before, people who use drugs have been dehumanized and criminalized. And I think starting from that point might be helpful. So, thank you.
All right, thank you. And Dr. German, one last comment for our attendees.
I think very similar. The day that I stopped worrying whether patients were truthful to me or what they were doing, I stopped worrying about that. All I cared about was treating the disease. And the minute that happened, our patients did well. And so it's really about getting back to that concept of this is a disease, not a moral failing. And as long as you treat it that way, your patients will have much, much better outcomes.
Thank you. And Dr. Rich, for our last word today.
Well, there was a disturbing note in the chat about Portugal, and there's been a lot of sort of negative stuff in the press around Portugal. But the fact of the matter is, last year in Rhode Island, we have a population of 1 million. We had 425 overdose deaths, most we've ever had. If we were doing what they were doing in Portugal, we would have had 8 overdose deaths. 8, in my mind, is unacceptable, but it's very different than 425. So whatever you say about Portugal, I think we would be foolish not to double down on what they've done. But anyhow, I'll leave it at that. I've already taken up too much time, but we didn't cover many things that need to be covered. So thank you again for organizing this.
No, absolutely. I know there's a lot more that can be discussed on this topic, and we'll definitely look forward as we continue this learning series to have additional conversation on this topic. But I thank all of you for your time today in presenting, and all of you who joined us today. I want to invite you to join us for our next webinar. We're going to be talking about Knockout Opiate Abuse Day. In New Jersey, October 6th has been declared a day of education and awareness on the opioid crisis. And we all can play a small role, whether it's sharing messages or sharing information on how to access naloxone, or sharing information about safe prescribing with our, our medical community. So we'll have a webinar coming up next month that's going to talk about all the resources, the free resources that are available to you and your community. And I hope that you can join us to find out how you can be part of that day on October 6th. And that webinar is going to be held on August 17th. So once again, I thank all of you for joining us today, and I wish everyone a good day, good remainder of their summer, and thank you again for joining us. Have a good day, everyone.